I'm your host, Aaron Boyson, and today we have my guest, Stacey Jones. So Stacey Jones is an associate professor and curriculum change lead at Coventry University. Stacey has worked in academia for the past 6.5 years, and prior to that worked as a specialist community dietitian, as well as a public health specialist dietitian. Stacey is undertaking a part-time PhD in the area of sarcopenia, looking at the role dietitians have in preventing and managing sarcopenia in older adults. She is passionate about leading forward the profession of dietetics and evidence-based practice, striving for excellence in patient caretaking in a holistic patient-centered approach. Stacey is a committee member of the UK BDA Older People Specialist Group and is also part of the EFAD, that's European Federation of Associated Dietitians, Older Adults Specialist Network. In her spare time, she enjoys running, cycling, and has more recently taken up open water swimming. In pre-COVID times, she enjoyed travelling the world and learning about different countries and cultures. Fortunately, she's got a bit more time on her hands because that's not available, and she's able to join us today. Thank you so much for joining us, Stacey.
Thanks for having me, Aaron. That's really great.
So obviously you've got a large background, a lot of interesting areas. So the innovation and the sort of pushing dietetics forward is something that one of the reasons why I really started this podcast, to interview some really inspiring and insightful people in the area of dietetics. And I wanted to discuss a little bit today, a little bit about the area you're working in, what brought you to that, and sort of how your journey's been so far. So if you could just sort of give me an outline of how you got where you currently are and where you currently are.
My background started with a degree in biology and sports science. I wasn't really sure what to do as a career, but I knew that I enjoyed learning about the human body, health, and also I had a very strong interest in exercise. So that then led me on to learning more about how exercise can actually impact on the human body and in health and disease. I was particularly interested in the nutritional aspects, which led me on to study a postgraduate diploma in dietetics to train as a dietitian. And when I first started working as a dietitian, I went straight into public health. I then went on to work as a community dietitian in a more clinical area, mainly working with patients who were malnourished, lots of elderly patients, and preventing malnutrition and nutritional support. Whilst supporting those patients, I felt that there were a lot more that we could do in order to prevent malnutrition and its consequences, and also to improve patient important outcomes. So for patients, it was about the ability to be independent, carry out activities of daily living, improvement in their mental well-being, their social life, the quality of life, and actual physical function. And so as a dietitian, whilst we were very much involved in giving advice to support their diet, their dietary intake, and improve their dietary intake, I felt that the measurements that we were taking around weight gain, BMI, were actually not that important to patients. And I felt that there was more that we could be doing in terms of our dietetic assessment and our dietetic involvement.
Was there
to
any
actually contribute? Sorry.
Was there any particular event that sort of led up to that? Because you said you were looking at sort of anthropometric measurements like weight and sort of helping people who have maybe had unintentional weight loss and helping them restore that weight. Do you have any sort of experiences or sort of a collection of experiences that you felt with patients that you felt that you could do more with?
Yes, actually, I had a lot of head and neck cancer patients who were on enteral tube feeds and actually still had a life around them, still going to work, still wanting to be able to do more and get back to their sort of active lifestyle, and were feeling like it was impacting on their sort of mood and their motivation, with the amount of muscle loss that they'd lost and the strength and sort of their ability in terms of their functional ability. So actually, when it came to weight gain, that wasn't actually as important, and they were often asking me things that they could be doing to help gain some more strength, and particularly around exercise. So that sort of led me to think about, and particularly in older, frail adults who were housebound maybe, had quite a high fear of falling, limited mobility, and that has impacted on their social aspects and their ability to go out and meet people and socialise. That has a knock-on effect on their mental health and well-being as well. So for me, it was about, could we be doing more for patients, rather than just restoring their weight and reducing malnutrition, to actually go one step further and enable them to take more control over their life and have that independence. So in terms of muscle mass and muscle gain, what interventions were actually effective in achieving gains in muscle strength and muscle gain and muscle function, rather than just thinking about the weight gain. And actually it did cross my mind a few times that were we just increasing people's weight, and therefore what weight were they actually putting on? Was it fat mass or was it actually muscle mass? Because if they were very sedentary, and they weren't actually doing any physical activity but they were gaining weight, would that just be almost increasing their risk through for other things in terms of increasing their increasing their fat mass and not their muscle mass?
And what did that lead you? When was the next step after you sort of had this realization? What was the next step in your life that led you to where you are now?
So this inspired me to think about exploring this area in terms of further research, and that was what led me really to move into academia. So I moved to Coventry University, teaching dietetic students, and that career really enabled me to have influence over the future generation of dietitians, thinking about what we learn at university and how that will then go on to impact practice and change practice. That was really inspiring, being able to have that impact in terms of the profession. And undertaking a PhD whilst I was at Coventry University gave me the opportunity to then explore the evidence behind malnutrition, exercise, nutrition, and the links that had with sarcopenia. Throughout the journey of my PhD, this has evolved really into looking at the role of the dietitian in prevention and management of sarcopenia, and more so, what could we be doing in terms of combining that exercise and nutrition approach, which is what the evidence suggests, and exploring the scope and the role of the dietitian, and potentially expanding that role or advancing that role to be more effective for the patients at the end of the day.
Yeah, I think that'll be really interesting to cover, and you wrote a paper on this topic about getting dietitians a little bit more involved with exercise and talking about that with patient cohorts. But maybe for the listeners that maybe not as familiar with it, what is sarcopenia, and how would you know if you saw a patient with sarcopenia?
Okay, so sarcopenia has been around for a very long time with various definitions, and it was only until recently that we had a consensus and definition for sarcopenia. So in 2010, the European Working Group for Sarcopenia in Older People published the first definition and consensus for sarcopenia, and this has since been updated in 2019, whereby sarcopenia is defined as a disease of muscle failure rooted in adverse muscle changes associated with aging but can occur in early life. So that's a definition from the European Working Group. And what we're really looking at is a combination of low muscle strength and low muscle mass for a diagnosis of sarcopenia to be confirmed. And then we look at the loss of physical function as an indication of the severity of sarcopenia.
How would you in say a clinic setting or an ward setting, how would a dietitian be able to recognize that in a patient? Would you just say, oh, they're pretty weak, they look pretty weak?
That's a great question, and actually it's about a holistic diagnosis. So we can look at muscle strength, muscle mass, and physical function, and have more objective measures of those. Some measures are more appropriate in a research setting, and can be quite costly, and we do have some measures that are quite easy and quick to do that would be more suitable in a sort of clinical setting with a patient or in a patient's own home. So in terms of what the European Working Group Sarcopenia recommends for diagnosis, so for muscle strength, they recommend using grip strength, using a hand grip dynamometer. So that's actually something that can be done out in the community. It could be done on a hospital ward. It could be done in the patient's own house. All we need is a hand grip dynamometer to take with us. And it doesn't take very long at all to measure a patient's grip strength. And then there are designated cut-off points to then diagnose sarcopenia. So for men, it would be a cut-off of less than 27 kilograms on the hand grip dynamometer, and for women less than 16 kilograms on the hand grip dynamometer. So that's a really simple, quick measurement that we can do to assess muscle strength. And it's a good surrogate measure for upper body strength and lower body strength as well with a hand grip. There's also something else that we can do, again, in the clinical setting, and it's called a sit to stand test. So it's really simple. Get our patient, sit on a chair comfortably, and we time how long it takes them to stand up and sit down from that chair 5 times without using their hands, in a safe and controlled manner. And that can be an indicator of lower leg strength or leg strength.
So hand grip measure and sit to stand test are really useful measures. And I've actually noticed that sometimes occupational therapists will do sit to stand tests, and you can often sort of either both do them and see any differences, or use their measures and use them in your assessment to be able to assess the patient's physical function. But that's great for, I work on a ward setting with some older adults, and I'm able to do some of these tests. But unfortunately, a lot of dietitians they increase in remote consultations, and that they might have to talk to someone over the phone. And just about using questionnaires like SARC-F, do those hold any weight? Would those be good tools to be able to assess a patient?
Yep, the SARC-F is a validated screening tool for sarcopenia, and it's 5 simple questions. It's based on a self-reported answer from the patient, but it's very quick and very simple to execute in a clinic setting, and even in a virtual consultation as well, so you don't need any physical measurements to take. So yeah, 5 simple questions. Each question is scored either a 0, a 1 or a 2, and then the total score of 10, and anything that scores 4 or more is a likely indicator that someone may have sarcopenia. So it's a really quick and easy screening tool to use, and it's recommended by the European Working Group for Sarcopenia.
Could you describe a little bit more about how we measure muscle mass and sort of the consequences of poor muscle function?
Yeah, so the gold standard really for measuring muscle mass would be using a DEXA scan or an MRI scan, but obviously they're very expensive and they're not easy to come by, and you would need to be trained as well in order to carry out those measurements. So we don't routinely use them. Bioelectrical impedance is a good measurement. So BIA is a good technique in order to look at body composition. So that can look at body fat percentage and fat-free mass. An easier and more surrogate method, a sort of a more practical method to use for dietitians, I think, would be to measure the calf circumference. So that's something that's really simple, just needs a tape measure. It's not too invasive for patients, and it's a good predictor of muscle mass in terms of older people. And a calf circumference cutoff of less than 31 centimetres would indicate a reduced muscle mass.
Why is it an issue when someone has very little muscle mass or a low level of muscle?
So reduced muscle mass is often seen also with a reduced level of strength, and that can affect our physical functioning as well. So some of the consequences of that could be a reduced independence to carry out activities of daily living, increased risk of frailty, a reduced quality of life, increased risk of falls and fractures, and an increased susceptibility to morbidity and mortality. And overall, this will have an increased knock-on effect on healthcare costs as well.
Obviously, this is a realm where sort of physical function and mobility is often looked at by physiotherapists, maybe occupational therapists, and dietitians are often have very weight-centric approaches to assessments. And often our screening tools, for example, the Malnutrition Universal, the MUST screening tool is used, and often that's very, very weight-centric assessment. So a patient gets referred to us because they've got low weight or lots of weight loss. Do dietitians really have a role in helping to prevent or treat sarcopenia?
I think we do. As dietitians, we will be seeing frail, malnourished patients with multiple comorbidities, and all of that will place patients at further risk of sarcopenia. So if they are malnourished, they're likely to be at risk of sarcopenia. I think we have a duty of care to offer a holistic, patient-centred approach with patients, and patients are at the centre of our care. People come as a whole, so we can't just look at individual problems, we have to look at the whole person. And I think we have a duty of care to prevent further disease or ill health as well. So if we can have a prevention approach to sarcopenia, then I think we should be looking at how we can be most effective within our role. And I think dietitians have excellent communication skills. We have excellent behaviour change skills as part of our nutritional counselling. So we're able to assess people's motivation, help them overcome barriers. We can provide them with education and raise an awareness of why something's important. And we can support the patients to set appropriate goals. And all of these are going to be really important when we talk about physical activity as well as nutrition. And I think if we're in a position where we've already built up that trust and that rapport with our patients, and we're seeing this population of patients anyway through our dietary counselling and dietary interventions, then we are in a really good place to then provide that holistic care and offer advice on physical activity, or as the care navigator, signpost patients to other services. And the evidence actually supports the best approach to prevent or treat sarcopenia is with a combined approach of nutrition and exercise interventions. So I think it's really important to combine the two.
So maybe we could start a little bit with those nutritional interventions. So a dietitian may be collecting sort of weight markers and seeing a person's weight go up. Now you're saying they should collect some, maybe a hand grip measure, a sit to stand measure. How are they going to use that measure in their assessment? How might they change their plan to optimize for muscle growth rather than just weight increase?
So the more measurements that we can take will help inform a proper, more thorough assessment of the patient, so that we can tailor our interventions more appropriately. And we can also then measure how effective those interventions have been by taking more measurements. So just taking weight or BMI doesn't necessarily tell us. We might see that their weight has gone up or their BMI has improved, but actually that doesn't tell us whether that's an improvement in muscle mass or strength, or whether that's had actually any impact on some of the patient important outcomes. So the more measurements we can take, the better and more detailed our nutritional diagnosis and plan can be.
Is there anything that dietitians could do to sort of optimize for that muscle growth? Is there anything that we could watch out for?
So as dietitians, nutrition is our bread and butter. So when we're thinking about recommendations for older adults, it's really important to consider their protein intake and their protein requirements. So it's been identified that the recommended dietary allowance for protein of 0.8 grams per kilogram is insufficient to meet the protein requirements for sustaining muscle mass in older adults. So the SBEN guidance on clinical nutrition and hydration in geriatrics recommends that protein intake should be at least 1 gram per kilogram per day in older adults. And further recommendations, so based on the ProteAge study, recommend that for older adults over 65 years old, we should be considering daily protein intake at least in the range of 1 to 1.2 grams per kilogram of protein per day. And even higher, so 1.2 to 1.5 in those undertaking exercise or those with chronic disease. And obviously caution should be taken with anybody with possible or existing renal impairment.
And now I've heard from, so often when new guidance comes out and they recommend sort of protein intakes of 1.5, dietitians might look at that and go, how on earth are we going to reach that with some of our patients? They already struggle to meet X previous guideline. Is there anything that, like, do you have any tips or any advice or anything that you could work towards? Because that's often the main sort of stumbling block I find in, firstly, even dietitians believing that it's possible, let alone the patients.
It is, and actually, in this particular age group, older adults may have things that have impacted on their appetite. They may have a poor appetite. They may have early satiety and not be able to eat large portions of food, get full very quickly. And for very various reasons and many reasons, appetite can be poor in older adults, and nutritional intake can actually be quite poor, and they may struggle to meet their nutritional requirements. And actually, what we know about older adults is not only does the protein intake need to be slightly higher, there's a blunting effect. So in older adults, we see that we actually need higher amounts of protein to actually trigger the muscle protein synthesis. So thinking about how much protein is actually needed at each mealtime is important as well. And the guidelines do recommend aiming for at least 20 grams of protein in each meal, which can be quite difficult to achieve when you've got somebody that maybe has a really poor appetite, or is limited in sort of their food choices or their ability to cook and prepare meals for themselves. As a dietitian, we should be using our individual dietary counselling skills. So we're actually looking at the patient, looking at their food preferences, their current intake, where possible using a food-based, a food-first approach. So, for example, looking at food fortification. So an example of that is adding 4 tablespoons of skimmed milk powder to a pint of milk, can add an additional 20 grams of protein to that pint of milk. So we can be advising on food first approaches, encouraging high protein snacks, encouraging protein foods with each meal, and considering oral nutritional supplementation where appropriate, but definitely taking the food first approach to counsel older adults, or to provide that advice for older adults on some of the higher protein foods that they could include at mealtime. So milky drinks, things like eggs with meal. It's quite a soft, easy protein food to manage if they're sort of not overly keen on eating meat or finding meat hard to chew, for example. So looking at food, fortifying the foods that they are having and the meals they are having to make them as nourishing as possible.
So let's move on to, so we've talked a little bit about nutritional interventions. Now let's talk about exercise. Now, do dietitians even have a role in talking about exercise? I mean, isn't that the physiotherapist's job? Aren't they the professionals in that area? We're not, I don't think I received any training on it in university. I just heard exercise is good. Resistance training is good to build muscle mass, but I wasn't given any sort of specifics that I would feel comfortable talking about it with a patient. Is it really our role?
That's an interesting question. I think it goes back really to thinking about our role as a holistic practitioner. So my research that I've been carrying out was to seek out the attitudes and views of dietitians and physiotherapists for the concept of dietitians offering prescribed exercise alongside nutritional counselling in older people. And actually, it's almost a continuum of what do we mean by prescribing exercise. So it can be really basic, and it could be a very first line approach and just giving out the sort of really simple move more messages and the government recommendations for exercise. And that could then progress onto more prescriptive exercise where we're actually giving more specific exercise advice, setting goals with patients and reviewing those patients. So when we say prescribing exercise, it comes down to, I think, everyone's individual interpretation of what we mean by that and perception of what we mean by prescribing exercise. For me, if we're talking about holistic care and making every contact count, then we should be considering encouraging basic physical activity in all patients as part of our holistic advice as dietitians, just like we would expect other professionals to offer first line advice on nutrition, so be it healthy eating for the general population or basic food fortification advice for those at risk of malnutrition. So I think everybody has a duty of care to talk about diet and exercise in the context of achieving general health outcomes. So simple government advice for the general population of 150 minutes of physical activity each week for older adults, in particular, ensuring that they carry out at least 2 days of strength training. And also the simple move more messages, so just reducing sedentary behaviour, encouraging someone to get up out of their chair every half an hour or every hour. So it can be very low risk, simple advice that we would be expecting to give to anybody. And if you think about, if we're in a clinic with somebody that was overweight and we're talking about obesity, I'm sure it would be second nature to talk about exercise as part of that weight loss strategy, and it goes hand in hand with diet and exercise. So why are we not talking about that with older people and older adults when we come to talk about strength and muscle mass?
Do you think that sometimes when we say things like strength training, it can be quite the words are quite charged? Like most people, when you talk about that, they view, oh, they've got to sign up for a gym membership, then they've got to talk to the guy at the gym, he's got to tell me about how to do all these different use all these different equipments for the sixth time because I've joined about 6 different times and cancelled my membership multiple times. And also it's COVID and increased risks. Do you ever feel like sometimes that phrasing needs to be altered a little bit in a consultation with patients, and further explanation needs to be given? And if so, what explanation would you offer to a patient?
Definitely. I think even the term exercise can mean different things to different people. So we tend to use maybe the terminology of physical activity as it sounds less threatening to somebody, particularly for older adults. The thought of exercise, it may get them thinking about going to a gym or having to run a marathon, and actually it doesn't mean that. It's any type of physical activity that will get your heart racing a little bit, that will increase your breathing rate, will make you work a little bit with a bit of effort. So yeah, I think the terminology that we use when we're talking about exercise is important, and maybe using the terms moving more or keeping active or physically active is much less threatening than the terms exercise. And I think you're completely right. When we talk about strength training or resistance training, it can be quite intimidating for a lot of people, and even some dietitians who think, well, that's a very specialist area. But actually what we mean by resistance and strength training is just working against a force or a resistance. And for some older people, in terms of their exercise capacity, that could mean using their own body weight as resistance. So just getting up and down out of a chair, or raising up onto your tiptoes and coming back down again could be enough to stimulate a sort of strength response. It doesn't have to be huge heavy weights, but it is important that it's a sufficient intensity of exercise that can produce those strength gains. So it's about sort of again tailoring that advice to the individual and looking at what their baseline is and what their sort of capabilities and capacity are for exercise, and then building slowly and gradually on that, just so that they can start to see some improvement.
Yeah, I remember I was at an event once and this exercise physiologist was talking and he recommended a website, I don't know if you're familiar with it, called Moving Medicine.
Yes, I've
Yeah.
heard of that.
Are things like that when someone needs a bit more of a bit more guidance in the idea of what exercises they could do, and it gives them things like bed exercises, chair exercises? Are things like that useful?
Definitely, and there are exercise programs out there, such as a Tago, which is a balanced-based exercise program, and so we could be signposting people onto these exercise programs that are run in the community through exercise referral schemes. I think talking to your local physiotherapist, see if they have any resources that have already been produced that they deem suitable for dietitians to be given out to patients as first line advice. So it could be chair-based exercises, it could be a leaflet or a website where people can follow exercises. A lot of these exercises are going to be done in their own home, unsupervised. So it's about balancing that risk really, and I think talking to your physiotherapist is the best way to go forward to find out if they've already got some resources that they would be happy for you to give out to patients, or signpost patients too.
Brilliant. And we've talked a lot about dietitians' perceptions, but what do physiotherapists think about dietitians giving out exercise information?
Yeah, so as part of my research, I recently carried out some interviews with exercise professionals and physiotherapists. Um, they were people that were working already in the context of older people within the community. And it was really to find out what their thoughts and their perceptions and their attitudes were to the prospect of dietitians potentially giving out exercise or physical activity advice to older adults alongside nutritional counselling in the context of sarcopenia management. Actually, I was quite surprised and pleasantly surprised by the enthusiasm of physiotherapists and exercise professionals to want to work with dietitians, and to hear that dietitians are actually interested in this area and they see it as being important, and they can see how exercise and nutrition are linked. They were very keen actually that you can't really have effective exercise without being sort of meeting nutritional requirements and having a good nutritional status. So actually the two complement each other and are both really important. So there were very much positive views of physiotherapists, that dietitians should be giving out basic move more messages, and if that could happen as part of the making every contact count and holistic advice that we're giving out, they could only see a benefit in that, particularly in terms of low risk activities like chair-based activities, or general, getting up out of a chair and moving around more and doing what the patient feels they're able to do, was quite low risk. But they were very keen to actually work more closely with dietitians, because they actually see that some of the patients they're seeing may be malnourished, or not taking in sufficient amounts of protein, or a good diet, and actually that has a negative impact then on the amount of exercise that they're able to do, and the sort of outcomes they're able to achieve with a patient. So I think there was sort of a mutual respect of how exercise and diet are both so important, and how dietitians and physiotherapists should be working more closely together with patients to achieve our goals at the end of the day, because we're both trying to achieve the same outcomes with patients, and that is to improve their quality of life, and their overall health status.
Just out of interest, if you could go back and be a community dietitian again, what would you do differently, and how would you work with the physiotherapist there?
I think actually learning about more about each other's roles. So having that opportunity maybe to shadow each other. So for the dietitians to go and spend some time with physiotherapists, and likewise for physios to come and spend some time with the dietitians, so that there's a deeper understanding of the role of each. I think providing training, so using the resources that we've got within departments and the specialist knowledge we've got. So if you can provide some in-house training for each other, so there's a bit of a trade-off in training, so that dietitians can, provide training to physiotherapists in order to give that first line advice, and ensure that the advice they're giving is consistent with the messages that are coming from the dietitians, and vice versa. So the physiotherapist can provide training for dietitians on providing that first line advice, and agreement on when to refer to the other profession. So maybe having some agreed pathways of these are the patients that are appropriate to have that first line advice, and this is when to refer on, and better communication really is what I got from both the dietitians and the physiotherapists through my research, is that if they're more aware that there's input from both professions and they can work together. So when the dietitian goes to see their patient, they can maybe ask how they're getting on with their exercises that have been prescribed by the physio. And likewise, when the physio goes to see the patient, they can ask about how they're getting on with the dietary advice, and making sure that they're eating appropriately to help with their exercise. That those reinforced messages and hearing it from different professionals time and time again may actually help motivate the patient and improve compliance and adherence to the advice. So actually there is benefit in both professions talking about diet and exercise, so the patient can see the link between the two and can see the importance.
Yeah, I remember I was reading maybe it was a sort of a reflection from a dietitian in relation to ICU nutrition, but it was talking about this idea of sort of extending roles of different professions, and it was about the overlapping nature of roles and how that helps with things like communication, working better at a team. And I think it's an area where I think there is room for improvement, if you agree, in the sort of the assessments that we do and how we manage patients, and also communicate with the MDT as a whole, in order to ensure that patients don't just gain fat mass but also gain muscle mass.
Definitely, I think MDT working is the key, really, is that we're all working together. At the end of the day, the patient should be at the centre of the care, and we are all working together to achieve the same goals. And I think when it comes to actual capacity versus demand of patients out there, so if we think about how many older adults are out there that are having this general decline in muscle mass and muscle strength, maybe they're more, they're becoming more sedentary, less physically active, maybe their diet isn't to the same quality as what it used to be, or factors affecting their dietary intake. And so they're sort of gradually on this decline of reduced muscle mass, reduced strength, reduced function. They may not be picked up by any healthcare professionals, dietitians or physiotherapists. So there are so many people out there that would benefit from this holistic advice, and even the early intervention and sort of preventative approach advice. So I think we don't have the capacity for all of those patients who are malnourished or frail to be seeing a physiotherapist, and we don't necessarily have the capacity either for all of those patients who are seeing physiotherapists to have access to a dietitian either. So I think the more we can be doing to make smarter use of our capacity in order to benefit patients. Yeah.
Whereas acute settings are restricted by the amount of hospital beds that you've got, community services can be infinitely expanded, infinitely sort of grow, like almost like you could serve more people. And I think as we learn more about the impact of nutrition, and we learn more about sort of at-risk category BMIs for older adults, correct me if I'm wrong, it's below 23 is at risk, not deemed as to be malnourished, but an sort of at-risk BMI.
Well, yes. So the GLIM criteria, which is the Global Leaders in Malnutrition, recently released some new criteria for diagnosis of malnutrition, and it actually refers to the BMI cutoffs for older adults, so adults over 70 years, of a slightly higher BMI. So anybody with a BMI of under 22 would be classed as at risk of malnutrition in the over 70 category. So actually it is a little bit advantageous to carry that little bit more weight in older age. But what we do need to be careful of is what is that makeup of the weight, and is that weight and BMI actually masking what might be a loss of muscle mass and a loss of muscle strength, and actually it's being masked by this increase in fat mass. So yeah, the more measurements we can take, the better our understanding will be of that patient's nutritional status in general.
So what role does the MUST screening tool have then? Is that still a useful screening tool, or do you think it needs to be revalidated? Well, all screening tools that involve not MUST in particular, but
yeah,
all screening tools that involve BMI in older adults, does it need revalidating to really be able to screen effectively? Because by that accord, you might already get a patient that's quite severely malnourished according to the GLIM criteria arrive to clinic, and wouldn't it be better to have early intervention in those patients?
Yes, so there are many screening tools out there that are validated and well used, and that their screening tools serve a purpose to try and identify those patients who may be at risk, in order to signpost them to appropriate interventions and referrals to appropriate professionals. So the MUST screening tool is widely used, and it's a validated tool. But I think the limitations are that it is only looking at BMI and weight change, and actually now we know that there is more to it than that, and sarcopenia is really important. So looking at measures of muscle mass and body composition. The GLIM criteria isn't a screening tool, it's a diagnosis tool. So actually within the GLIM, it still advises that you use screening tools as a first line approach, and then using the GLIM criteria to then further assess that risk of malnutrition. So the GLIM is a really good tool, and I think we should all be starting to use that within our practice, because it looks at not just BMI, but it also looks at muscle mass as well, and then we can be using things like the SARC-F tool, which is a really simple screening tool, questionnaire type tool to look at sarcopenia risk. And I think as practitioners, as dietitians, we should then be taking more detailed assessment in terms of looking at muscle mass and strength, to better inform our decision making and our nutritional interventions, and also if it can help demonstrate effectiveness of dietitians and measure our outcomes, then I think we should be all doing that as well.
Definitely. And I've started to use things like Sarcopenia, hand grip a lot more in patients on the ward, but also in clinic. And I found them be really helpful, not only for me to gauge the patient's progress and me to get a rough assessment of how much sort of, obviously it's not a direct, but obviously if the hand grip goes up and the weight's going up at sort of a steady rate, you can sort of infer that they're probably gaining muscle mass from that assessment. But also I found it motivates people quite a lot, especially the hand grip. They go, oh, once you told me I was below average, I got very upset by that. So I went home. I did everything you said, and I've been working really hard. Hope it's good and they show improvement. But it's whereas like the weight is a bit like it usually works better with males, and that's probably due to the way society sort of conditioned males to have the appearance of being strong and things like that. But I think you can see that the patient doesn't really care about their weight, but they care about these sort of other measures, that the activities of daily living. And when we take that into our assessment and inform the patient about our assessment process, I found myself it really helps the patient understand the importance of nutrition, and also as a motivating tool to enable them to achieve the goals that they desire, instead of just saying this aim is to increase weight or optimize nutritional status by stabilizing weight. Often patients don't care as much as we do about measures like that.
Definitely. I think something like hand grip can be a real motivating tool for patients. And if, maybe they're not seeing their weight go up, but they're seeing that they've got an improved grip strength, then that can be a motivating factor to see that it is making a difference. And that's probably more important than the actual weight gain itself. And it's very simple and quick and easy to use.
Perfect. Thank you so much for joining me today on this podcast, this Dietetics Digest podcast. And all of the show notes will be available, and we'll put references to anything discussed. So the Global Leadership Initiative in Malnutrition, we'll put references there, and there's a few ones that I want to share, and a few other tools, like an explanation of what the SARC-F tool is, and also references to some of the research that Stacey's been doing on her PhD. I'll also put social media information for Stacey, the one she wants to direct you to, so you can keep up to date with her work and keep informed with the exciting new things she's learning, and everything she sort of her musings on Twitter as well, so you can keep updated with those. I don't know if you wanted to include anything else in the show notes, or is that quite a comprehensive list of things?
Yeah, I can provide you with some. So for example, the European Working Group of Sarcopenia, I can provide that document, because I've mentioned that. I've mentioned the GLIM criteria, and I've mentioned the SPEN guidelines, so I can provide references for those as well.
Perfect. Thank you so much. Thank you so much for your time, and hopefully you can get back to your traveling soon, and fingers crossed.
Fingers crossed for all of us. But yes, thank you very much for having me, Aaron. It's been really delightful to talk to you today.
Thank you very much. Thank you.